You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for October 24th, 2025. This week, the PREVENT score in hypertension, GLP-1 mechanism of action in cardiovascular disease, coronary artery disease type and statin benefit, and heart failure hospitalizations as an endpoint. The first topic is using the PREVENT calculator to determine cardiovascular risk. And this is a study, a post hoc analysis of the SPRINT trial. So we'll start by saying that treatment of high blood pressure obviously can be one of the most important primary prevention therapies. But, like so many conditions these days, normal is being debrided lower and lower. And I get it, because high blood pressure is like LDL exposure, right? It doesn't do harm so much in weeks or months, but years and decades. So longer exposure to abnormal blood pressure surely has a compounding effect. Now, recent guidance has advocated for a risk-based decision wherein patients with mild hypertension are treated based on an assessment of their cardiovascular risk. The old way to do this was with the pooled cohort equation. This was the same one used in statin decisions. Simply put, you calculate a risk threshold, and if you're over that, you treat. Under that 10-year risk, you hold off and observe. Now, obviously, if the blood pressure is high enough, you treat, but in the intermediate ranges, say stage 1 hypertension, you use these risk estimates. Now, the AHA has come up with a replacement for the pooled cohort equation, which, recall, uses age, sex, total cholesterol, HDL, systolic blood pressure, medicine use, smoking, diabetes, and statin use. The new score, the PREVENT score, is felt to be more accurate. It gets rid of the race categories. It includes kidney function, BMI, urine albumin measures, zip code, and even hemoglobin A1C. PREVENT score also accounts for competing risks of non-cardiovascular death. Now, many studies show that it is a more accurate predictor than the PCE. But the tension is that the more accurate race-neutral score down risks a huge number of patients, which lowered the number of, quote, statin-eligible patients. This week, Jack has published a study from a group at UPenn, and they looked at how the PREVENT score affects outcomes in the SPRINT trial. The SPRINT trial was intensive versus standard blood pressure goals. Remember, 120 target versus 140. And in SPRINT, which enrolled patients with a high cardiovascular disease risk, a systolic blood pressure between 130 and 180, but not diabetes, found a 25% reduction in MACE. And MACE in that trial was MI, any other ACS, stroke, heart failure, or CV death. That was a 25% reduction with intensive versus standard blood pressure goals. So the goal of this current analysis was to quantify the relative and absolute benefits and harms of intensive versus standard blood pressure goals by the new PREVENT risk levels. Now, before I say anything, we should state that secondary analyses like these are only possible because government-sponsored studies are open to other researchers, which is a good thing and should be the norm in any trial used to guide medical practice. Okay, PREVENT scores are designed to predict first events. So the researchers only looked at the population in SPRINT who did not have a previous CV event, so-called primary prevention component of SPRINT. This was about 6,500 of 9,300 total SPRINT patients. The first thing to say is that a previous study found that 98% of patients in SPRINT have their 10-year risk reclassified lower with the PREVENT relative to the PCE scores. Now, this was already known going into the study, hence the tension, right? Because lower risk means less treatment. So, first finding was that using PREVENT in the reanalysis, the authors found that about 16% of SPRINT patients had lower borderline risk, that's less than 7.5%. 62% of SPRINT were intermediate risk, and that's 7.5% to 20% 10-year risk, and 22% of SPRINT were considered high risk or greater than 20%. They then looked at relative and absolute risk reductions of SPRINT outcomes in the intensive versus standard blood pressure treatment arms, basically a subgroup analysis with 3 subgroups. And for relative risk reduction, intensive blood pressure treatment, that is a target of 120 millimeters of mercury, showed consistent benefits across all risk groups compared to standard treatment. The hazard ratios were for low risk 0.74, intermediate 0.70, and for high 0.85. But for absolute risk reduction, it was definitely more illuminating. For the low prevent score risk, it was only 0.2% reduction over 4 years. Intermediate, it was a 1.5% absolute risk reduction. And for the high risk, 2.4% reduction. So the NNTs to prevent one MACE outcome over the 4 years of sprint would be 567 and 42, respectively. Now, I know what you might be thinking. You might be thinking, Mandrola, you've gone on for minutes and haven't told us the effect on adverse events. Because remember that in the sprint trial, there was a penalty for intensive treatment in that there was more syncope, hypotension, electrolyte abnormalities, and AKI in the intensive arm. The authors report a hazard ratio for harms for the intensive versus standard based on risk. So it was 12% higher, 1.12 for the low risk group, 1.66 or 66% higher for intermediate, and that turned out to be statistically significant, and 28% more adverse events for the high risk group. And absolute risk increases were 0.2% for the low, 2.7% increase for intermediate, and 1.8% for high risk. Now pause there for a second. Basically, the NNT is the same as the NNH, number needed to harm, for the low borderline risk, but the number needed to harm is greater in the intermediate risk. It's a net increase of 37 extra adverse events. And for high risk, it was in favor of the intensive treatment, 2.4 versus 1.8, more risk reduction than harm. But a somewhat surprising finding was that while cardiovascular disease benefits increased with higher baseline risk, 0.2, 1.5, 2.4% absolute risk reduction, adverse events did not follow exactly the same pattern. The intermediate risk group had the highest absolute adverse event rate, 2.7%, even higher than the high risk group, which was 1.8%. And of course, the intermediate group had the most power because of a larger number of patients. So, my comments. While higher risk patients did get more absolute cardiovascular disease benefit, as expected, the harms were highest in the intermediate risk group, which was sort of unexpected. The clinical translation would be that the highest prevent risk patients, more than 20% 10-year risk, get more benefit than harm, but the net benefit harm calculus is uncertain in intermediate risk patients. And for the low-risk patients, which is weird to say because supposedly Sprint only enrolled high-risk patients, there was minimal benefit and minimal risk, like no effect in either direction. Now, you might say that in the case of a wash, where the MACE reduction is equal to the increase in adverse events incidence, that it's better to prevent a cardiovascular event because they are worse than an adverse event. And I think that's probably correct because an MI is certainly worse than an electrolyte abnormality. But you know, as I was reading this paper, I started to think, hey, wait a second. For every subgroup of PREVENT, there did not appear to be a really great net benefit. That is, MACE reduction versus increase in adverse events. I mean, for the low risk, it was 0.2 versus 0.2, almost nothing happening. For the intermediate risk, there was more adverse events than MACE reduction. It was 2.7 more adverse events versus 1.5 fewer CV events. And for high risk, it was slightly in favor of treatment, 2.4% reduction versus 1.8% increase. But then I thought, I don't think you can analyze trials like this. To do so would be to chop up subgroups into underpowered groups. I mean, SPRINT was powered to find a reduction in MACE for the entire population. And it did, including a strong signal of CV death and all-cause death. So sure, SPRINT can have criticisms. There's criticisms, external validity, given the incredibly intense blood pressure measurements. Another criticism, the fact that patients in the standard arm had therapy de-escalated when they had blood pressures in the perfect range, and this isn't something that we would do clinically. But this particular secondary analysis should not majorly affect how we translate SPRINT at the bedside, I think. I think we can say that the PREVENT score clearly declassifies risk lower, and this may move us to hold off treatment when the risk gets below 7.5%. But for the vast majority of sprint-like patients, we should probably lean on the main trial results when discussing with our patients. And as I have said many times on this podcast before, a lot of who and how much we treat turns on patient preferences. And there are minimizers and maximizers who interpret these kinds of data differently. A minimizer is going to look at these absolute risk reductions and say it's not worth taking a pill for the rest of my life, or at least long term. But a maximizer, a person who wants to reduce their risk as much as possible, will take the daily pill. Or I guess we could use mild hypertension as an incentive to lose weight, to exercise, and to reduce alcohol intake. Who knew? Okay, next topic. GLP-1 agonist mechanism of action in cardiovascular disease. The Lancet has published an interesting sub-analysis of the SELECT trial of semaglutide versus placebo in patients with obesity and established cardiovascular disease. Recall that the SELECT trial found that semaglutide reduced MACE versus placebo by a statistically significant 20%. SELECT showed that in these obese patients, GLP-1 drugs are disease-modifying. Most remarkably, I'd say, on top of excellent medical therapy. So these patients in SELECT had lipid-lowering therapy was like 90%. So the GLP-1s were added disease-modifying effect. But the question is, how did semaglutide accomplish this? Was it just the weight loss? Because it did cause weight loss. Or was it something about the GLP-1 agonism? It's an important question because if your patient achieves GLP level weight loss with diet and exercise, is that sufficient? So the SELECT investigators presented an analysis studying the relationship between baseline adiposity measures, treatment-induced adiposity changes, and then subsequent MACE risk. And in this analysis, the risk of MACE occurring after 20 weeks was assessed between patients by adiposity changes in the first 20 weeks. Recall that in the main trial of 17,000 patients, semaglutide reduced MACE versus placebo, and there was consistent benefits across all baseline weight and waist circumference categories. Treatment with semaglutide reduced the incidence of MACE with no heterogeneity in treatment effect across measures of body habitus at baseline. And so the results here was that within each treatment group, the risk of MACE was lower in patients with lower baseline adiposity measures. In the semaglutide group, there was no relationship of weight loss in the first 20 weeks to subsequent MACE events. Pause there. In the semaglutide group, there was no relationship of weight loss in the first 20 weeks to subsequent MACE events. In the semaglutide group, there was a linear trend, however, towards decreased MACE by waist circumference changes at week 20. Here, the hazard ratio was 0.91, and this was not seen in the placebo group. There was no evidence that the semaglutide effect on MACE was mediated by time-varying weight loss, as the unadjusted hazard ratio of 0.80 for the risk of MACE with semaglutide versus placebo was not attenuated after adjustment for weight loss as a time-varying covariate. But in contrast, an early change in waist circumference was estimated to mediate or mark 33% of the semaglutide reduction in the later risk of MACE. And there were no substantial differences in serious adverse events in patients treated with semaglutide according to the strata of change in weight or waist circumference. The authors then wrote, sort of concluded, quote, "We now show that early in-trial weight loss was not related to cardiovascular benefit after 20 weeks. By contrast, there was a linear relationship between waist circumference, which is a measure of central adiposity, and treatment effects of semaglutide. But even so, waist circumference reduction accounted for no more than 33% of the MACE effect. These findings suggest that the cardioprotective effects of semaglutide extend beyond its impact on adiposity, with important implications for clinical practice and understanding of the mechanisms responsible for the benefits of GLP-1 receptor agonist." And they add, quote, "Our findings have substantial implications for both clinical practice and healthcare policy. Most patients who are treated for cardiovascular disease have a BMI of at least 27, suggesting that many patients may benefit from semaglutide to reduce adverse cardiovascular outcomes. And the early cardiovascular benefits of semaglutide in SELECT were not related to weight change and only modestly related to waist circumference change." So my comments. I don't know about this. Select in this analysis was sponsored by Novo Nordisk. Many of the authors have conflicts with Novo Nordisk. This comment above seems like a talking point to expand use of the drugs beyond patients in this trial. While it's possible, I say it's possible that waist circumference, which is a measure of visceral fat, which may have greater adverse effects than total body weight, and it's possible GLP-1 drugs may exert its protective effect at least partially through reduction of visceral fat. It's also possible that this paper is statistical noise. The authors admit that this is basically an observational analysis from an RCT. Now, I wonder why they ignored changes of BMI, for instance. Again, emphasis on I feel analytic flexibility here. Like the previous analysis sprint, perhaps it's best to hew closest to the main trial. We don't know exactly how statins reduce cardiac events beyond LDL cholesterol reduction. It's probably going to be the same with GLP-1s. It's certainly the same with SGLT2 inhibitors. We're not sure how they exert their beneficial effect in heart failure. I think what it would be nice to see, I don't know if it will be seen, is to see the SELECT trial replicated once or twice, perhaps with a different GLP-1 receptor agonist. Then, of course, we would have multiple studies to look into these mechanisms. All right, the third topic, statins and coronary artery disease phenotype noted on CTA and outcomes. Now, speaking of statins and mechanisms, the JACC Imaging Journal has published a provocative study from a Hungarian team, and they looked at coronary artery disease on coronary CTA and statin effects on CV outcomes. It's an interesting question on whether statin use can be personalized. But this study, despite its attention that it got online, I think is deeply flawed. The authors made use of the Hungarian national health data. They had about 11,000 patients who had had a coronary CTA for symptoms. They then looked at how statin use interacted with outcomes going forward. Now, the first finding was obvious. The worse the coronary artery disease on scan, the greater the use of statins, and this is good, and it's normal, and that's good. But they then choose a highly specific parameter, and that is a 10% increase in statin use over time. And using that as the variable, they say that they found a statistically significant association with a lower risk of cardiovascular events in patients with coronary disease on their scan, but not in patients without coronary disease. And I'll read you the hazard ratio for both. So with coronary artery disease on the scan, statin use was associated with a 5% adjusted hazard ratio 0.95, confidence interval 0.92 to 0.99. Without coronary disease on the scan, hazard ratio 0.95, 95% confidence intervals 0.84 to 1.07. Now, did you notice that? The point estimate of the hazard ratio was the same. What was different was the confidence intervals, or the certainty intervals. I'm not a statistical expert, but these numbers don't compute with the claim that 10% higher use of statins resulted in no reduction in MACE in people without CAD, but did result in a reduction in people with CAD. The authors concluded, and this is a copy and paste, quote, statin efficacy to decrease MACE depends on CAD phenotypes and increases with the extent and severity of disease and in the presence of high-risk plaques. Patients without CAD have no benefit from statin therapy regarding MACE. Coronary CTA may play a pivotal role in optimizing statin allocation for personalized treatment decisions to prevent MACE. My comments. I am shocked that this gets by peer reviewers. Now, we know from numerous RCTs that statins reduce cardiovascular events in most patients, excluding those with dialysis and advanced heart failure. I mean, the statin trials were done way before there were CTA scans, and you can be sure in those seminal statin trials that there were patients with and without CTA-seen CAD. I'll link, for instance, to a USPSTF meta-analysis of statins and primary prevention, that is, patients without CAD. This included 22 trials and 90,000 patients, finds clear benefit in MACE reduction, albeit, I would admit, with a modest absolute risk reduction. And there are numerous problems with this analysis. First is that you cannot say that 2 point estimates, which are both 0.95, are different because they have different confidence intervals. You can say one estimate had more certainty than the other, but not that one showed no effect and the other showed a positive effect. The second problem with this paper is analytic flexibility. The 10% statin increase is just made up. What about a 5% increase, or a 13% increase, or a 20% increase? I ask these questions because A, 10% just seems so arbitrary, and B, when the authors looked at statin use versus no statin use, they found a hazard ratio of 0.86, or 14% lower MACE rate in patients with CAD. But again, the authors claim there was no association with CAD. Why? Because the confidence intervals of that hazard ratio went from 0.68 to 1.08, and it had a p-value of 0.18. I think it's curious because 10% more statin coverage led to a 5% risk reduction, hazard ratio 0.95, but going from 0% to any statin was 14% reduction, hazard ratio 0.86. The fact that any statin, which might be 1% of the time or 100% of the time, reduces MACE more than a 10% increase doesn't seem exactly plausible. What is plausible to me here is confounding, namely that those who would accept statin or increase use of statin are likely healthier, more motivated, or different, such as they would have lower rates of MACE. Another clue that statin patients are different in this analysis is that the MACE events were actually death or MI. Death was 3.1% of all events and MI 0.9%. And then when you go into the supplement, you find similar interaction assessments between statin use and death and MI. You'd expect statins to strongly interact with MI, but not so much with death, which can occur for many non-cardiac reasons. And the fact that the interaction signals between statins and death are similar suggests that the signals in this study were confounded, and that is that healthier patients took statins. The paper and its conclusions are hazardous because it is highly likely that LDL cholesterol lowering effects of drugs accumulate over time. So I believe it's possible, likely even, that primary prevention therapies have their greatest effects in those who have yet to develop serious disease. Now you might push back and say, come on, Mandrola, the absolute risk reduction are greater in secondary versus primary prevention for statins. And I would say, yes, this is true when you look at 3 to 5 year trials. But what about 10, 20, 30 years? What about the 40-year-old who avoids an LAD infarct? That person is surely to gain more life extension than a 75-year-old who avoids an MI. All right, next topic is the problem with hospitalization endpoints in heart failure trials. I don't normally cover viewpoint articles, but I'm making an exception today. The European Journal of Heart Failure has an excellent essay on the problem with hospitalization endpoints in heart failure trials. The first author is Sam Straw from Leeds. I have spoken about this issue many times, and it was delightful to see this issue reach the Academy. Their first point is that heart failure therapy was established in trials that measured death. Then, as therapies were added sequentially, patients stopped dying so much. And then you needed larger and larger trials. But trials can only be so large, so the next step was to look at other endpoints, enter hospitalizations. Now, hospitalizations for heart failure may be a substantial event, the authors write. A hospitalization for heart failure is often followed by a permanent decline in quality of life, functional status, or independence. And this, the authors write, may be due to direct harms of the hospitalization or simply reflect disease progression. I think it's really interesting that they would consider iatrogenic harm so strongly. But it's true, isn't it? Hospitalization for heart failure could lead to overzealous diuresis, inappropriate angiography, venous thromboembolism. All are possible outcomes of being stuck in a hospital bed. So, on the one hand, they say a hospitalization for heart failure is indeed a good endpoint to reduce. But then they go on to list 5 problems with heart failure hospitalizations as an endpoint in trials. Problem number 1, mortality and heart failure hospitalizations are not equivalent endpoints. It's fine when a trial shows that a therapy reduces both, but it's more difficult when the results are discordant, isn't it? They cite the Fine Arts heart failure trial of finerenone, where the drug reduces heart failure hospitalizations but has no effect on CV death or all-cause death. The trial is viewed as positive, but the DIDGE trial, many years ago showed nearly the same thing. In DIGE, there was a 28% reduction in heart failure hospitalizations, but no effect on mortality, and DIGE is widely thought of as a negative trial. So a possible solution to this unequal importance is a hierarchical endpoint. But the authors downplay this solution. They cite the Triluminate trials, where benefit was seen in unblinded quality of life endpoint. Or perhaps as bad was the DAPA-MI trial, where the endpoints were changed to include cardiometabolic endpoints, such as new diabetes or body weight reductions. Problem number 2, a hospital's mission is not always due to heart failure. And this is one of my favorite points, because in the HFpEF trials, such as Emperor Preserved, EMPA did reduce heart failure hospitalizations, but heart failure was only 18% of the total hospitalizations. And no patient ever cares what the cause of their hospitalization was, they just don't want to be in the hospital. Problem number 3, they cite hospitalizations are complex, inconsistently defined, and not exclusively due to heart failure. Their point here is that an admission for pulmonary edema and a ventilator run is a lot different from an admission for peripheral edema and body weight being increased. Yet trials use a binary classification, heart failure hospitalization or not. Now, you would think blinded adjudication would help, but central committees use hospital notes from unblinded physicians. Problem number 4, and this is really important, hospitalization is a decision. Unlike death, which is unbiased, to admit a patient to a hospital requires a subjective judgment from a clinician. If this clinician knows the treatment assignment, there can be bias, whether it's conscious or not. Quote, "This is a particular concern in unblinded trials of medical devices where physicians may have lower thresholds to admit untreated patients. In the Reshape HF2, which was MitraClip, reductions in hospitalization and improvements in quality of life were not matched by changes in mortality or objective markers." Problem number 5, patients guide hospitalization decisions, so bias is not limited to clinicians. A patient who is aware of their treatment may alter their behavior. Few better examples exist here than the early TAVR trial, where asymptomatic patients with severe AS who just passed a treadmill turned symptomatic rapidly after being randomized to the surveillance arm. They had clear subtraction anxiety. Now, the authors list possible solutions such as standardized definitions of a heart failure hospitalization, a report of total hospitalization burden, and I could not agree with that more. Every heart failure hospitalization trial should have total hospitalizations right under that. They also say that investigator-reported and adjudicated outcomes may be important. And finally, perhaps the most important recommendation that's been written in a medical journal this year is that these authors call for device trials to have sham arms. Of course this is true, because there's no way to assess subjective endpoints in patients who know their treatment assignment. Okay, that's almost it for this week in cardiology. I want to make one brief closing comment. This paper made me think of something that came up this week. This week, I had 2 debates on left atrial appendage occlusion with interventional colleagues. One was in EP, interventional, and one was in structural. I don't know why I'm still debating appendage occlusion, but people are asking me to do it. But on both occasions, my colleagues cited the popularity of the procedure as evidence. And when faced with dubious evidence from the trials, their response was basically, "Come on, John, this stuff is complicated. I know this procedure works, and so does the entire field. Go home with your nuance. Give patients options for non-pharmacologic treatment of stroke prevention." I have to say, this shunning of nuance is sad. I mean, cardiology was once a leader in evidence generation. The nuance matters. There was no need to design flawed trials in the past, like Option, or ignore inconvenient results, like Prevail. I mean, we had the lytic trials, primary PCI trials, ACE, beta blocker, MRAs, and heart failure. Now, though, as we've gotten so good at therapy, it's harder to show benefit. I really hope our field does not devolve into something that looks like a religious experience. I would hate to see cardiology lose its edge in the realm of evidence-based practice. These things matter. Nuance matters. Critical appraisal matters. So that's it for this week in cardiology. As always, I'm grateful you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating, write us a review. If you don't agree with something I said, please send me a note, write a comment on the website. I love listener feedback. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.